webinar series in January, February, and August, September. Theme for current series is CT scan diagnosis, and today's topic is CT abdomen diagnosis. We are absolutely thrilled to have such a distinguished group of medical professionals, academicians, clinicians, PG scholars, and students from various corners of India joining us today. Your presence reflects a shared commitment to advancing our understanding and expertise in imaging technologies. Myself, Dr. Trupti Yavatkar, Associate Professor, Department of रोग निदान एवं विकृति विज्ञान, SC मुथा आर्यंगला वैद्यक महाविद्यालय सातारा, working as President of RVPGA Female Wing, welcomes you all to our today's webinar. This webinar is conducted by RVPGA, रोग निदान विकृति विज्ञान PG Association, and is approved by Maharashtra Council of Indian Medicine, Mumbai. I am honored to welcome our distinguished speaker, Dr. Anand Hadgaonkar sir, renowned radiologist, for today's webinar. But before we dive in, I would like to brief you all about the RVPGA Association. Introduction of our association and its achievements. As we all know, ours is a fast-growing organization which is committed for the welfare of our Nidan community primarily and Ayurveda fraternity in general. Our organization RVPGA was formed in the year 2016 under the able and dynamic leadership of Dr. Subhash Wage with the aim to give the legal status of pathologist and radiologist to the PGs of Rog Nidan. Our organization is duly registered under Societies Act of 1860 at Charity Commissioner Office, Nagpur. Postgraduate students, teachers of Rog Nidan Vikruti Vignan and Chaya Vikiran Vignan can become our members. Ours is the only organization which is fighting for the lawful rights of Rog Nidan and Vikruti Vignan PGs. Even the NCSM has also directed State of Maharashtra to consider RVPGA as stakeholder in the constitution of pathology regulatory body of the state. RVPGA is pursuing this matter with state and central government. Not only this, RVPGA is constantly pursuing the implementation of NCSM salary structure in all the private Ayurvedic colleges across the nation. All the communications and details are uploaded on our website www.rvpganagpur.com. Activities performed by our organization. Regular conduction of online webinars and offline seminars, both on national and international platforms. So far now, we conducted 37 national webinars on different diagnostic topics, 4 national workshops, and 3 national conferences, as well as hands-on training program for PGs at our 35 plus partner NABL accredited pathology laboratory across Maharashtra. Publication of research papers of Nidan students and faculties in our peer-reviewed International Journal of Diagnostics and Research, IJDR. Our journal is enlisted in 8 databases. 8 issues have been published, and our current issue had a record number of 22 articles published just within 2 years of commencement of our journal. Interested can visit the journal website www.ijdrindia.com. We also have edited book volume series through our international publications RIPI, which is registered in Government of India's ISBN portal. Those who want to contribute book chapter can visit RIPI website www.rvpgaIIP.com. We have published All India Rog Nidan PG thesis book consisting of all the Rog Nidan PG titles from 1985 to 2023 for the easy reference of our PGs and faculties. We also have our YouTube channel, Facebook page, and Instagram page where you can see the educational activities live and past. To update our colleagues and students with recent updates, we have launched 3 diploma courses like DAPT, DXDT, DECM. Similarly, we have launched 8 certificate courses like CMIV, CMPD, CMDT, CEDT, etc. To know more about the courses, visit https://rvpganagpur.com. E-News Bulletin biannually published highlighting the achievements of our members. We are giving legal fight for the issues of the Rog Nidan and Vikruti Vignan PGs at appropriate forum. This is all about RVPGA Association. Moving forward with our today's webinar, we all know that in the dynamic landscape of modern medicine, accurate and timely diagnosis is paramount, especially when it comes to the complex conditions affecting the abdomen and abdominal cavity. Disorders within this region can have profound impact on the personal or patient health. This is where computed tomography or CT stands as an indispensable tool. For decades, the CT scan has revolutionized our ability to visualize the intricate anatomy of the abdomen. Unlike conventional X-rays, CT provides detailed cross-sectional slices of the body, allowing us to see the structures in 3 dimensions and with remarkable clarity. Throughout this webinar, our esteemed speakers, who are leaders in their respective fields, will share their valuable expertise, present compiling case studies, and discuss latest advancements in the CT abdomen diagnosis. It is my privilege to introduce our today's speaker, Dr. Anand Hadgaonkar Sir, MBBS MD, Professor and HOD, Radio Diagnosis, Datta Mega Medical College, Nagpur. Sir has done MBBS from PDMMC at Amravati in 1996. Further pursued his MD from IGMC, Nagpur in 2005. Sir is working as professor and head at Datta Mega Medical College, Nagpur, ex-consultant radiologist at National Cancer Institute, Nagpur, ex-associate professor at GMC, Nagpur and BJ Medical College, Pune. Worked as assistant professor at Indira Gandhi Government Medical College, Nagpur, Grant Medical College and JJ Group of Hospitals, Mumbai. He have more than 30 national and international publications till date. Editor Journal-in-Chief, Journal of Applied and Clinical Radiology, JACR, Secretary Maharashtra College of Radiology MCR and Secretary Vidarbha Radiology Association VIDRAD. Area of interest conventional and cross-sectional imaging. So without taking much time, let's begin with our knowledge journey. I request Dr. Anand Hadgaonkar sir to please start the lecture. Over to you, sir.
सर्वप्रथम सर्वांना तान्ह्या पोळ्याच्या आणि पोळ्या पाडव्याच्या शुभेच्छा. आज विदर्भातला फार मोठा सण आहे. ऍक्च्युली काल संध्याकाळीच आपल्या इथे पोळा साजरा करण्यात आलेला आहे. तर सर्वप्रथम मी शेअर करतो. थँक्स अ लॉट फॉर गिव्हिंग मी दिस अपॉर्च्युनिटी अँड वी विल जस्ट स्टार्ट विथ. कॅन यू सी दिस प्रेझेंटेशन?
No, sir. Still. Yes, sir.
Okay, so you can see. Now we can start with. So today's topic is diagnostic interpretation of CT abdomen. In last lecture, I had covered CT basics. We know about a CT is based on same principle as that of X-ray. So principle being same, so it is having radiation as a one of the adverse effect or the drawback. So exposure to the radiation is there. Some other additional things also we had seen. We had also seen that before invention of ultrasound and CT, laparotomy was the only option. So we have to cut open the abdomen and look for the pathologies. But in 70s and 80s, that is that particular decade, everything changed. Ultrasound as well as CT, everything became easily available. And at that time, the new era started with non-invasive sort of, that is the imaging. So imaging, ultrasound was the first modality. So ultrasound is it is easily available. However, it is having some limitations like this modality is operator dependent. Although it is giving some real-time information, so in good hands, ultrasound is the ultimate modality. And if at all you are going ahead and looking for some gallbladder pathologies, so ultrasound is the modality of choice for polythiasis or even GB malignancy as such. But the next modality is the CCT. CCT, that is a contrast enhanced CT. So if CT scan done properly with IV contrast and additional oral and rectal contrast if necessary, it is one-stop answer for most of the abdominal pathology, especially those pathology when patient is presenting in emergency with acute abdomen. Some revision of last lecture that we had talked about basics of the CT. So we all know about it is, although images are acquired in axial section, we can go ahead with the MPR. MPR, that is multi-planar reconstruction into coronal as well as sagittal plane. So no more it was called CAT-CT, that is computed axial tomography, rather it is called computed tomography nowadays. Then we had also seen about this particular thing, that is a grayscale. So how this grayscale was quantified, and this quantified grayscale, which was right from 0 up to -1000, representing water to air, that is on the darker side, and brighter side it was 0 to +1000, which was representing a brighter side, that is a bone. We had seen that 5 basic densities, or the 5 basic shades of gray what we had. Now we have multiple shades of gray, and we can even diagnose these soft tissue parts separately. Like we are having soft tissue, we are having water density. These are overlap in X-ray. However, we can differentiate them properly. Even different tissues have different HU values. This different, like liver is having higher HU value as compared to the spleen. So that you can make it out. Everything can be seen very well with with good knowledge of the shades of the gray. One can see blood with, it is actually one of most important benefit what we get in CT. So all bright things we can make out very clearly. Then we are having a benefit of contrast. So I will talk about everything in detail later on. We had also gone through A, B, C, D. That approach, what we think it can just make you easy to approach any sort of CT scan. The most important thing is the basic, that is anatomy. So you must be thorough in anatomy. You must know about the anatomy. You must know the liver is on the right side, spleen and stomach bubble is on the left side. Such a basic knowledge of anatomy is must while interpreting CT scan or while looking at all these images. So anatomy is the first and foremost part. Later, what is black and what is bright. So what we are looking at, black part, that is representing the darker, that is air, part that is cortical bone. So while talking about a brighter part, just remember, for calcium or for calculi, both are brighter part, even bone. So if you are looking at fracture, for all these things, means calcium, including calculi and bone, best is to go ahead with CT scan. So CT scan show you calcifications very well as fractures very well. So it is the modality of choice for interpretation of these things. Given a contrast, it can add to the differentiation between these soft tissue structures even better. So we will just go through all these details later on. While talking about a density, which is basically a shades of gray, we had also gone through this Hounsfield scale, or the scale of gray scale, by which we can differentiate right from air up to brightest part, that is the contrast. So I will just go through one by one. So in odd 45 minutes or 1 hour, we will go through different CT abdomen scan types. We will talk about normal CT anatomy in detail. So that is one of the important tasks what we will be doing together. Then we will try to just go through few pathologies and know about some CT guided procedures later on. At first, about types of scan. CT scan can be acquired without contrast or the with contrast. Whenever it is acquired without contrast, we call it non-contrast study or non-enhance. So any CT or NCCT, these are common words which are used for non-contrast study of abdomen. Non-contrast study of abdomen is usually done for looking for the calcification, looking for fractures. Whenever one want to look for a soft tissue structures, it is better to give contrast so that one can differentiate between different type of all these soft tissue structures. So stones are seen like we are having a CTKUB or kidney, ureter and bladder region. Although we don't call it CTKUB, we call it non-contrast CT of abdomen. Then we are having contrast CT. Contrast CT, you can even call it conventional CT, because conventionally CT abdomen, it is advisable to go ahead with the contrast. This contrast can be along with IV, one has to add oral or the rectal contrast. Angiography is just a modification of the contrast study when we are acquiring images much before the arterial or the venous phase, and we are also adding extra amount of contrast with a different sort of injection speed. So we need injector for taking proper angiography images. Double triple contrast, again it is a modification of IV contrast study. We will go in detail. Some special procedures are there which are CT enteroclysis. It is just a modification of the same technique. So CT enterography or enteroclysis, then we are having CT urography or colonography. All these are just a modification in conventional contrast CT. Non-contrast CT study, as we had seen, calculi are seen better along with, if we are, last lecture we had seen about windowing. You can window the image in soft tissue or in a bone sort of window. So in bone window, you can see bony structures better. Calcifications are also seen best in both of it. So better it can be seen even in bone window. So one can look for calcification. Here is the axial CT film which is showing renal calculi. This renal calculi, this is renal pelvis, this is right kidney, this is left kidney, and one can see this calculi. So these bright things which is of bone density or the calcification, these are nothing but a renal calculi. One can even make out dilated pelvis. So there is some hydronephrosis, which is dilated pelvic calyceal system. So there is a mild hydronephrosis and bilateral pelvic calculi. This calculi or the calcification may not be always in collecting system. Sometimes it may be seen in this cortical region. See, in this case of medullary nephrocalcinosis, when these calcifications are seen here in the medulla. So these are medullary calcification. Likewise, we can have cortical calcification. So cortical or medullary nephrocalcinosis. So these calcifications are seen much better in non-contrast study. However, just okay, I think someone touched the pain here. So I cannot remove it. Just I will try to. Just I am trying to erase, but I will have to erase it in every film, I think. Okay. So we will just move to the next one. I will take another one. We are moving to the contrast study. When we are moving to the contrast study, there is some prerequisite before going ahead with the contrast study. So we are giving IV contrast. IV contrast, it is always a non-ionic nowadays, but contrast can be iodinated or the non-iodinated contrast, or non-ionic or ionic or non-ionic iodinated contrast. So we are nowadays using iodinated contrast. Sorry, non-ionic iodinated contrast. Uh, This contrast can be given IV, and prerequisite, as I was talking about, is at first patient should be NBM. NBM is nil by mouth. 4 to 6 hours of fasting is required before taking patient for the contrast study. One must know about KFT, that is kidney function test, and serum creatinine values, which is normally 0.8 to 1.2, which should be within normal limit. Even we can just have a EGFR, that is effective glomerular filtration rate, what we can calculate by knowing male, female, weight of the patient, age of the patient rather. And that way we can calculate it and we can take a patient. Normal EGFR is more than 60, but we can take that patient for contrast even if that EGFR is between 40 to 60 with little modification in the type of drug we are using, or that is a contrast. We usually use isosmolar contrast, and we can even sometimes reduce the dose. So we can take patient if he is non-allergic to the contrast for the contrast study. Hydration is one of the important things. So we will talk about it later on in detail. So contrast study, it makes soft tissue differentiation are really great to see. And we can differentiate between, not only we know about the vascularity of the pathology, what we are looking at, but we are also looking at all arteries, veins, vascular structures, and also the normal vascularity which is seen in different normal anatomical parts in abdomen. See here is actually ovarian cyst, what one can see here in pelvis. So this ovarian cyst is there, and what one can see is multiple sort of internal septations. So septations, one can see enhancement. So enhancing is ovarian cyst we are sure about. Although it appears like that of hydatid cyst, this is not at all hydatid cyst. Hydatid cyst will not enhance. So what one can see is the peripheral enhancement. If septal enhancement is there, it is more in favor of some sort of aggressive or the malignancy. However, non-enhancing thin septations, they are benign in nature. So we are not going in detail about characterization of the lesion. Rather, we will try to know about what are the additional benefits of the contrast study. One can see here a displaced bowel loop. So we had given oral contrast as well. This patient is given IV contrast, oral contrast, and rectal contrast. So rectal contrast is also given in order to delineate large bowel loops. One can see a brighter sort of appearance of this rectal contrast, what is given. At the same time, one can see little less brighter, that is the oral contrast, which is also specifying small bowel loops. So we are having opacification of the small bowel loop, large bowel loop. We are having opacification of here. What one can see is the artery, here is a vein. So IV contrast, oral contrast, and rectal contrast, all these things can add to a differentiation of the soft tissue and characterization of any mass or lesion if you will come across in abdomen CT. Additional benefit of all these things, we had seen VRT, if you remember, along with MPR, that is minimum and maximum, MIP, that is minimum and maximum intensity projection. We had also learned that we can even have this such type of colorful angiography sort of images with volume rendered imaging. So this is a volume rendered imaging with color coding. What one can see is proper aortogram and all the vessels, all the branches which are supplying different organs. See here, in this particular, we had also already talked about, for taking angiogram, one need to have a proper injection rate, and we also need larger quantity of contrast. So contrast amount is also more, and acquisition needs at least more than, if at all 16 slice CT is there, multi-slice CT, the acquisition is quite easier to get. So here is aortogram with all these branches, and we can have such type of reconstruction or the VRT images later on. Now we will talk about multi-phase contrast, double contrast, triple contrast. Depending on the pathologies, we may go ahead with double, triple, or multi-phase contrast. Double contrast is usually what we go ahead with. We take arterial, then we take venous, and that's all. So few people may stop here. However, multiple pathologies can be missed if you are taking only these two phases. Triple phase, they are usually indicated for some sort of hepatic lesions. So hepatic lesions, we are adding portal venous phase as well. So we are having arterial phase, portal venous phase, and venous phase proper. So likewise, in hepatic lesions, we go ahead with triple phase study. You can go ahead with a modified double phase or the triple phase study in pancreatic malignancy as well. So in pancreatic malignancy, if you want to, or pancreatic pathology, you want to look for some arterial involvement, venous thrombosis, arterial thrombosis, or aneurysm formation, you will go ahead with the arterial phase. And arterial phase, later on, you may go ahead with the venous phase. You may prefer to have a delayed phase imaging. And urography is a special procedure where we are taking a delayed phase during the filling of ureter, and you can even go ahead with even later on that we can add another phase of full bladder. So the imaging you have to adjust as per the pathology. If at all you are having adrenal mass to image with, I may add a 15 minutes post-contrast images in order to know about adrenal washout. So likewise, you have to modify all these studies whenever you are looking at different pathologies. So pathologies with some modification is really important. See here, one of the example here, what one can see here is a peripheral nodular sort of enhancement, which is seen in the arterial plane. In plane, I can see just a hypodensity, what is here in right lobe of the liver, segment 6. Here what I see is there is peripheral sort of nodular peripheral enhancement, what is seen here. But if I follow, this is the arterial phase. One can see enhancement of artery and venous had just started. See here in venous phase, there is the increasing or the centripetal filling. I have taken this delayed image as 10 to 15 minutes, and what I can see is there is progressive centripetal filling in this particular lesion. It is giving us a diagnosis that this is nothing but a giant hemangioma. So hemangioma is a benign condition where there is a peripheral nodular enhancement of these vessels, which is equal to the adjacent artery. In venous phase and in delayed phase, one can see centripetal sort of filling. So this is centripetal filling, very typical of hemangioma. At the same time, in this triple phase or the multiple phase study, you can even diagnose SCC. SCC is having very typical presentation. So this is SCC case where one can see isotohypodense lesion here in the right lobe of liver. And what one can see in arterial phase enhancement is there. So arterial phase enhancement and venous phase washout, as one can see in this particular case. So early enhancement is there and early washout. So this is the case of SCC. With raised alpha fetoprotein level, you are almost sure about these two markers. You don't need to even biopsy these cases, and these cases are nothing but hepatocellular carcinoma. In this case, although cirrhotic changes are not there, this patient is hepatitis B positive. So if at all patient is hepatitis B or C positive and patient is having cirrhosis, SCC is the common malignancy you may frequently come across. Moving to some special procedures, here what one can see is CT urography. We had talked about CT urography when we had added or we had modified the procedures. Although plenty of people, they are using different techniques to get the CT urography done. Few people just prefer, they may inject a contrast before so that bladder will be full while acquiring the images in the arterial phase. So you can have either, or you can have your own type of methodology for taking proper CT urography with minimum radiation exposure. What one can go ahead with, one can have a bladder field. Later on, you can just go ahead with. So you can give some part of the contrast. Usually 20 ml of contrast is given hour prior, and then 500 ml of the fluid what we are giving IV. That way the bladder will be full with contrast, and later on we will just follow it with the arterial phase and the venous phase sort of imaging. So in which you can even see the arterial sort of arterial phase or the angiographic sort of phase. Then later on you can have even a proper excretion which is visualized in the ureter, and you can get such type of picture. So this one is CT urography. So this is one of the methods. There are plenty of methods explained. When we are talking about virtual colonoscopy, it is just a virtual, it is VRT. VRT, that is same procedure with whenever the bowel is filled with air, or we are putting some air into the large bowel, and you can visualize these polyps or the internal sort of narrowing or masses in much better clarity, and it can give the image like that of colonoscopy. So we call it colonoscopy. Similarly, we can have a virtual bronchoscopy. So without entering the colonoscope, you can get this picture like. So this one is a beauty of CT scanner. This one is elastography, enterography, what we have done. In enterography, we are giving a negative oral contrast. Negative oral contrast, preferably we are giving a contrast which will be retained there in the bowel. So you may go ahead with, there are water, or you can mix water with some sort of retainer, or which can expander. Some negative contrasts are also available in market. So enterography, preferably with the negative contrast, can delineate small bowel with much better clarity, and you can even see enhancement of uh, bowel wall, and you can make out some pathologies, even obstruction in better way. So angiography can be done with positive contrast, but preferably we do it with negative contrast. Some added benefits are there. So these are procedures or different type of CT acquisition, what we had seen. We will move to the anatomy. Anatomy is really simple. You all are well aware of all these organs. So we will just try to go through different parts. At first, just an overview of the anatomy. We are having a liver on the right side. Here is the spleen on the left side. Stomach is here in the left subdiaphragmatic subphrenic region. One can see here the right kidney and left kidney along with left adrenal and right adrenal as a retroperitoneal organ. These are psoas muscles. Jejunal loops, they are frequently seen more on left side. They are crossing the midline. Then we are having characterless ileal loop. So stomach, here one can see the fundus of stomach. One can see pancreas here. This one is liver. So let's go through the axial images rather. Again, just a pre-check before taking patient for a contrast examination. We had already asked patient to be NBM or nil by mouth or fasting, should be there for 4 to 6 hours. Usually we prefer uh, fasting in not only the patients with which are undergoing contrast, but all those patients who might be needing some sedation as well. So in order to avoid aspiration, we will ask this patient to be NBM, KFT for same renal functions, because contrast can lead to acute kidney injury or already damaged kidneys can undergo a further damage. So we avoid giving contrast in renally deranged patients. We had also talked about effective glomerular filtration rate, EGFR, and this modification will be based on by the radiologist depending on the case he is coming across. Regarding the hydration, I said I will tell you later on. So few patients, they need proper hydration, especially those patients like multiple myeloma and diabetes. These patients, they are having a danger of renal failure with contrast. So contrast-induced renal failure, higher chances are there in multiple myeloma and diabetes patient. So in these patients, we properly hydrate the patient before the procedure as well as after the procedures in order to avoid harm due to the contrast. In case of adrenal masses, we are not only modifying the process, we are modifying the procedure. We are taking 15 minutes post-contrast additional sequence, as well as we are also looking for the patient there one must keep a standby of the anesthetist, as adrenal crisis may settle in these cases of adrenal masses, especially those cases who are having pheochromocytoma. Then about thyroid masses, although thyroid masses, we can easily do contrast study, but these patients, if at all malignancy is diagnosed, and these patients may require further treatment with the radioiodine. So given contrast may interfere with the uptake of the radioiodine. That's why you may have to avoid giving contrast in thyroid masses, or you have to inform the surgeon, inform the treating physician. Of course, if contrast is given, they may have to delay radioiodine treatment depending on the PSA values, or depending on the TSH value. So anatomy, let's go through some images, axial images. See here, this one is liver, axial image at the level of liver. So here we are having a liver left lobe, liver right lobe. In between, what one can see here is the hepatic veins and also a portal vein. Here is the spleen, is a part of upper pole of left kidney. What is seen? This one is adrenal. So we are having adrenal here. I will just try to take the page. So here is the adrenal. Here is the right adrenal. So left adrenal, right adrenal, spleen, liver. So liver, then not to forget about a fundus of stomach. Okay, just we'll just go through these images and removing these. Just we will make a pause. Okay. So we are at a lower level of liver. So here is the liver. This one is the gallbladder. What one can see here is the gallbladder. This is right kidney. This is left kidney. And you can see a part of pylorus of the stomach here. A pancreas. I will just search for pancreas. Here one can see head of the pancreas. Here is a part of the body. Here one can see a pancreas. So here is the pancreas. This is body of pancreas, tail of pancreas. Look at the great vessels. Here is aorta and this one is IVC. So we are having IVC here, aorta. Not to forget about the portal vein here. So this one is the portal vein. So this triad is there, aorta, IVC and portal vein. This one is a pancreas. Here we are having spleen. Just one by one, we will try to assess as many as organs possible, including bowel loops. If we look at the bowel loops, stomach, you know it by position and typical appearance. So stomach will appear like a stomach, what I will say. So it is in the fundus is in the left subdiaphragmatic region. Then you are having a body and the pylorus. Then you are having the duodenal first part, that is the duodenal cap, C loop of the duodenum. Then you are having this duodenum, that is the third part of duodenum, fourth part of the duodenum, which is seen here. So likewise, one has to follow different small bowel, large bowel loops. Stomach can be seen easily, as do the large bowel. However, make it a habit to follow these bowel loops, depending on their characteristic. Like jejunal loops, they are having vulvally connivents. That is a complete sort of mucosal folds. What can be seen, as in radiograph, you can see here as well. Then look for the uh, abnormalities. Rather a large bowel loop, you can look for the hostel fold. And small bowel, it is characterless. So look for characters and try to make it out. Look for the diameter. The normal diameter criteria 369 rule. We'll talk about it later on. So we are moving ahead with these images, these sections. Now we are at lower section. We had already gone through. Here one can see superior mesenteric artery here. So superior mesenteric artery and vein, these are important structures one has to pay attention to and look at their position. So you are having superior mesenteric vein on the right and artery vein is on the right and artery is on the left. See here. We are moving here again to the next level. One can see a large bowel loop here is the part of ascending colon, and here is coalesced part of the descending colon. Then aortic bifurcation, that level was, one can see right and left, common iliac, veins as well as arteries. So here arteries and veins, arteries are these arteries and these are veins, and they are here colored red and blue for your easy understanding. Not only vascular structures are seen better in contrast, even the soft tissue contrast is enhanced. Soft tissue differentiation is enhanced. So one can see here a sigmoid. On X-ray, we were looking at different bowel loops depending on the presence of air within. So if air is within these bowel loops, then only you were able to see on X-ray. But on CT scan, you are having some added benefit. You can easily make out all these bowel loops very well. with addition of negative contrast. So we are talking about some negative contrast. As in enterography, we were using mannitol. So mannitol is somewhat, it can retain fluid for a longer period. So we can use water mixed with mannitol or negative contrast, what is available commercially. That is again a mannitol based. Then we are having positive contrast. So oral positive contrast is available, as well as low density barium is also available as a oral contrast, but that will give positive contrast. So you may not be able to see a mucosal lining or bowel wall pathologies whenever you are giving positive contrast. So just be aware of whenever you are looking for some pathology related to bowel wall, rather go ahead with negative contrast than the positive contrast. See here, the presence of air within the sigmoid. So this is the sigmoid loop, what one can see here. Moving ahead to the pelvic organs. So here is a patient, a male patient. So we are having a bladder here. No, it's a female patient, sorry. Yeah. It's a female patient. One can see a part of uterus here. So here is a uterus. So this is a bladder. This is a part of vagina. What one can see, this is a rectum. So all these organs as seen here. So all these are axial CT sections, what we had gone through, and we tried to make out as many parts as possible. At last, about these are the gluteal muscles. One can see upper thigh muscles. One can see iliacus muscle here. One can see psoas on the posterior aspect. At the same time, you can see parietal abdominal wall, this skin, subcutaneous fat. One can see rectus abdominis here. One can see these internal, external, oblique, and transversus abdominis, these three muscles which are forming anterior abdominal wall. These are all glutei. Then back muscles, latissimus dorsi, and all paraspinal muscles one can see here, this bulk of paraspinal muscles. Okay, so we had covered somewhat axial anatomy as much as we can look for. Again, just a revise. Usually images, whenever we are taking abdominal CT axial images, we start from the level of either rather a pulmonary vein level or the left atrium level. Here we had started from the interventricular septum level. One by one, at this particular level, that is a heart level. This one is left ventricle. This one is the right ventricle. As one can see here is the IVC. So IVC is entering into the, right atrium. Here is a part of left atrium, what is visualized here. Then we are having esophagus as seen here posteriorly. Esophagus is seen as a collapsed tube. So in a collapsed tube, you may not be able to make out esophageal pathologies better unless and until you are giving oral contrast. So in such, if at all you are suspecting some esophageal, lower esophageal sort of pathology, one has to give oral contrast. Whether it is a CT chest also, you'll have to do it with added oral contrast so that one can visualize or one can just distend, preferably give positive contrast so you can distend properly the esophagus and you can also make out pathologies at the same time. Here is a liver. We had just one by one we'll go through. One can see these hepatic veins. These hepatic veins are converging into IVC. Here is a aorta. Again, this is a left branch of the portal vein. This one is intrahepatic IVC or the IVC. This one is aorta. This one is a stomach with positive contrast. So in this particular case, we had given positive contrast. This is a spleen. Again, this one is the right branch of portal vein, IVC, aorta, stomach, and spleen with liver. So liver, left lobe and right lobe. Anatomically, they are divided by the presence of falciform ligament. Although on CT scan, we separate different hepatic segment based on a portal vein. So portal vein, above the level of bifurcation of portal vein, these are different segments. Below the level of bifurcation of portal vein or this horizontal portal vein, these are different segments. So below the level of portal vein, one can see anterior and posterior segments. These are 5 and 6. Above the level of portal vein, these are 7 and 8. So 6 and 7, these are posterior segments of the right lobe, while 5 and 8, these are anterior segments of right lobe of liver. In left lobe, we are having 1, 2, 3, 4. So 1 is actually not a part of left lobe, it is a separate lobe. This one is the caudate lobe. It is having separate blood supply and having venous drainage as well. So it can have a direct drainage into IVC. So this part is a first segment. So this one is the caudate lobe. Then you are having 2, 3, 4A and 4B. So 2, 3, 4A and 4B, all these are left lobe segments across even a falciform ligament. So 4A and 4B, they are across falciform ligament. The segment below is 2 and above is 3. So we are having 3, 4, 2, sorry. Below is 2 and above is 3. So we are having 2, 3, 4, 5. So segments, if at all you will look at this numbering, so it is anti-clockwise on the left lobe, along the left lobe, while it is clockwise on the in the right side of the in the right lobe of liver. From the liver, we are moving to the a segment below, that is a pancreas. So the segment just below the bifurcation of the portal vein, one can see here a head of the pancreas. Here is the body of pancreas and tail of the pancreas, which is seen here in relation to the hilum of the spleen. So one can see here, tail of the pancreas. This is head and body of the pancreas. This one is, what one can see here is the portal vein. We are in portal vein. We had seen that portal vein, IVC and aorta, this triangle we had seen before as well. Then this one is a left adrenal. So part of left adrenal is seen here. Then we are having left kidney. Again, moving down, so upper pole of right kidney has started appearing. At the same time, one can see pylorus and second part of duodenum has also started appearing. This one is spleen. See here, here we are having pancreatic head only with uncinate process. Look at the SMV and SMA relation. So SMV is on right side while SMA on the left side. This relation, if at all is reverse, it means there is a non-rotation. We will just go through few images later on. Here, what one can see is IVC. These are renal veins. This one is aorta, right, left kidney, spleen. These are all jejunal images. What you have, then you are having a colon. So colon is there. So here is the transverse colon. The transverse colon has just started appearing. Here is the ascending colon. This one is the descending colon. Look at the jejunal loops. So jejunal loops, one can see these valvular connivents, how these valvular connivents or the mucosal folds will appear on CT scan. So these are jejunal loops. Then we are having colonic loop with which are characterized by the hostile folds. So incomplete mucosal folds, here hostile folds as seen, and the typical position of the colon. So whether it transverse ascending or descending colon, you can diagnose any pathology, or you can even start characterizing these particular bowel loops based on their position and their typical characteristic of the hostile folds in large bowel. If at all you are having some trouble, you can just start from below. So here we are having rectum, then sigmoid, descending, here is the ascending colon, and likewise. So large bowel is somewhat easy to trace as compared to the small bowel. One can see here small bowel or characterless ileal loops as well. Then you can similarly, you can trace arteries or veins. You can just follow them up to the end, as one can see here in bilateral inguinal region. These are again, look at the uterus. So look at the ovaries. Here is the right ovary, here is the left ovary. So we'll stop anatomy here. We will just move to few pathologies. So these are coronal sections showing the same. So anterior to posterior, if at all we are starting from the posterior to anterior. As one can see here is retroperitoneal organs like right kidney. Here you have left kidney, psoas muscle, part of liver and part of spleen. Then just we are forwarding all these images and we are looking at liver, spleen, right and left kidneys, and so on. Again, moving forward, then look at the ventral abdomen. One can see liver here. There is some enlargement of this right lobe, as one can see. Subcostally, it is extending certainly more than 2 centimeters. This one is ascending colon. This one is descending colon, part of transverse colon. So likewise, you can just see here the bladder, and you can even go ahead with a sagittal section to look for different organs. So these are about the soft tissue. Not only you have to look for the soft tissue abnormalities, you will have to also look for some bony abnormalities, if at all. So bony abnormalities one can make out by making the windowing in bone window. So go ahead with a little darker window where you can see bones better as compared to the soft tissue. It is at your mouse click. So in just a single mouse click, you can have all these findings. Indications are plenty. So whenever I say about when abdominal CT scan we want to go ahead with, indications are like detection, diagnosis, staging, and treatment. So detection is at first, when your patient is coming to you with some symptomatology, you should be able to detect some pathology, and that too should be able to explain whatever symptoms that pathology is causing. The next thing what one has to go ahead with, wherever you had detected that pathology or abnormality, you should be able to diagnose, reach up to the, if at all it is in the right iliac fossa, you can see a blind ending tubular structure which is having diameter more than 6 mm with a with adjacent fat stranding, or there is some obstruction, there is some calcification or leak within, you are sure about this is appendicitis. So likewise, you can reach to the diagnosis. Sometimes you may come across some abnormality, maybe a benign inflammatory pathology like that of pancreatitis. See, pancreatitis is that you may find there is some process which is going on over the period. So we are having some sort of timeline you can give. So you can even give timeline like this is a chronic pancreatitis with acute episode nowadays, means recent acute episodes. All is acute on chronic pancreatitis. If it is a malignancy, you can, if it is okay, malignancy will go ahead with. So malignancy, you may have to stage it. So that patient might be having the mass with local spread, with lymph nodal spread, or with distant spread into the liver or distant spread into the skeleton, whatever visualized in that particular CT scan, or lung. So likewise, one has to stage the disease, not only locally lymph nodal spread, or metastatic spread. One has to even sometimes may have to go ahead with diagnosing it properly, means for histopath diagnosis, one may have to go ahead with some sort of biopsy or the FNSC. So that is for the neoplastic lesions or the malignancy, whether it is malignancy, what type of malignancy it is, and what is the staging of malignancy. So likewise, one can diagnose these things based on CT scan. Few things can be treated. So that is the interventional things. So one can even go ahead with intervention and treatment of few of these pathologies as well. So we will just go through few, I think last 10 or 15 minutes only. So we will just start rapidly. At first about the situs. Situs, we all know that liver is on the right, spleen and stomach is on the left. There is levocardia. However, you may come across exactly opposites or mirror sort of image, as in this particular case of situs inversus totalis, where liver is on the left side, while along with the dextrocardia, you are having stomach on the right, and rest of the bowel loops are arranged likewise. You may have some sort of in-between presentation, that is incomplete sort of presentation as well. So there may not be a situs solitus, but it will be a situs ambiguous sort of presentation. The gut or the GIT undergoes rotation during a development. So if at all there is no rotation of the small and large bowel loop, then you may come across a non-rotation. In non-rotation, what one can see, all small bowel loops, they are on right side, and large bowel loops, they are on left side. There can be a picture, intermittent picture, or there can be even a ventral and dorsal sort of. As we all know, ascending and descending colon, they are rather a retroperitoneal structures. And we are having transverse and sigmoid colon having a intraperitoneal structures. So you may come across reverse rotation as well, but this is very rare. Frequently, what you may come across is type 1 or the non-rotation sort of thing. Here, sometimes you may come across a reverse position, as we had seen that SMA is on right and SMB is on right and SMA on left. So exactly opposite position, you may come across with such type of rotation giving whirlpool sort of pattern. This may be a isolated sort of midgut malrotation. Midgut malrotation may lead to midgut volvulus with proximal obstruction. How will you diagnose bowel obstruction? Again, we were talking about 3-6-9 rule. So 3 is the diameter for the small bowel, 6 is for the large bowel, and 9 for the cecum. So more than 9 mm, there are chances of cecal perforation. More than centimeter, sorry. Yeah. So it is a 3 centimeter, 6 centimeter, and 9 centimeter rule for the bowel obstruction. You may come across air fluid levels. You may be able to make out a particular transition zone, as in this particular case, where the jejunal loops, they are filled up with, we had given a negative contrast here. So this negative contrast, like mannitol, you can just give mannitol with water. So in 2 liters of water, we can put a 25 ml of mannitol and just add honey to taste. And you can just give patient a oral contrast and he can just slowly ingest such amount of contrast. Then one can be able to even see such type of transition zone. So this is with negative contrast. Similar thing you can repeat with positive contrast. If you are giving positive contrast, then also you can make out transition zone with much better clarity. This is the case of sigmoid volvulus, although it can be diagnosed very well on X-ray or the scanofilm. So here is what additional things one can see is a rotation of the vessels, what one can see clearly on the CT scan. So that is the added advantage. Again, intussusception can be seen where there is a telescoping of, here what one can see is a small bowel, that is the ileal loop or the distal ileal loop or terminal ileal loop into the colon. So this one is the ileocolic sort of, ileocolic type of intussusception, as one can see here. Sometimes you may see the lead point, as one can see here, a lymph node as a lead point. So here is a intussusception with, this one is a mesentery, fat-laden mesentery. Here one can see mesenteric fat. So this one is a typical appearance of the intussusception. We call it a target sign. Even on CT, we call it target sign. And this one is the Hayford sign. So it is appearing like a Hayford. Or so this one is the case of intussusception. Not infrequently, you may come across a free gas. So we know about a presence of gas. Presence of gas is usually there in the proximal small bowel and distal bowel. So whenever such type of large amount of gas, as shown here in pink and star. So if at all such type of free gas is there, even one can see a small amount of fluid is also there. There is ascites and air fluid level, what one can see here. These are all seen in perforation. Usually whenever such a large amount of gas is there, usually it is a upper GI, mostly the gastric perforation or else a peptic ulcer perforation, that is a first part duodenal perforation. So it is a perforation of the gastric ulcer or the peptic ulcer. Regarding hepatic pathologies can be a focal, like here one can see, although very large in size, these are hepatic cysts. Liver cysts are frequently seen things. Hemangioma, we had seen a hemangioma with typical appearance with centripetal filling and typical nodular sort of enhancement in arterial phase. And we had also taken a late phase images in hemangioma to look for the filling properly. Then the malignant lesion, we had also seen hepatocellular carcinoma can be diagnosed with much more confidence if we are doing multi-phase sort of imaging. Here is a patient with cirrhosis. So cirrhosis is a diffuse sort of disorder. Whenever we talk about diffuse sort of hepatic lesions, not to forget about steatosis, that is the fatty change. Fatty change can be a focal or such a generalized sort of thing. So here is a generalized fatty change. One can see usually the density of liver is much more than that of the spleen, but one can see here density is much less and you may find it in negative. So instead of being a 45 HU, it might be a -20 or below HU. If difference of more than 10 HU is there between the splenic density and the liver density, you can comment about a fatty infiltration of the liver. See here, is the cirrhotic liver with typical margins which are appearing irregular and nodular. Here is another case where this is cirrhotic liver. Normally, liver density should be between 40 to 45, but as one can see here, this is much denser as compared to. So this one is a deposition of iron in the stomach. So this one is hemochromatosis of the hemosiderotic liver. This one is typical appearance of hemangioma. Again, similar example, but we had seen a better example before. So multiple hemangiomas as well as multiple metastasis also you may come across. So multiple metastasis as seen in this particular case. SCC, how it appears. So usually it is having arterial phase enhancement and portal or venous phase washout. Liver is usually a cirrhotic or it is hepatitis A or B positive. See here. Then we will move to the acute pancreatitis. Last 5 minutes, what we will just brush up all these pathologies. So acute pancreatitis may present with normal size pancreas or pancreas may be bulky and edematous, may have some non-enhancing part like that of necrotizing sort of pancreatitis. So this one is pancreatitis with bulky pancreas, with peripancreatic inflammation, peripancreatic fat stranding, peripancreatic fluid collection, associated ascites. So all these findings are there. You may go ahead with identifying the risk or the prognosis of this particular patient by doing modified CT severity index, by looking at the necrotic areas, by looking at the collections. Next stage is subacute to chronic pancreatitis. In subacute pancreatitis is characterized by a small pseudocyst. This one is a chronic pancreatitis where there is a dilatation of the main pancreatic duct, and one can even see intraductal as well as a parenchymal sort of calcification. So presence of calcification, dilated MPD, these are hallmark of chronic pancreatitis. So this is the case of chronic pancreatitis. We'll just go through the IVU procedure we have already discussed about. So IVU can give a beautiful pictures with virtual sort of, we can even go ahead with VRT images. So volume rendered images to look for the proper with color labeled. We can just get the pictures like these. See here is a case of ectopic kidneys. So right kidney is low lying in the pelvis, left kidney is at normal position. Here is the horseshoe kidney with fused lower poles. Horseshoe kidneys are always low lying. So these fused lower pole images are there. See here, here is the higher position of both kidneys. These are, although subdiaphragmatic, they may appear as a thoracic kidneys. Here is a polycystic kidney disease, so right and left. One can see multiple right and left kidney with multiple cysts. So polycystic kidney will almost a 40% of the patients, they have hepatic cyst as well. So this patient is having cyst in liver and cyst in spleen. Sometimes cyst can be seen in pancreas and liver as well. So this one is a polycystic kidney disease. It can be ARPKD, that is autosomal recessive polycystic kidney disease, is infantile variant, and adult variant is ADPKD. It is autosomal dominant. So autosomal dominant have a later presentation. Infantile is having earlier presentation. So infantile may be associated with periportal fibrosis. And this one is the case of calculi we have already discussed with. So not only renal calculi, you can even make out ureteric calculi with much better precision. Always remember, this ureter is having 3 sites of constriction, one at PUJ, pelviureteric junction, another one at the iliac crossing. So here what one can see, the calculi, they are either here at PUJ or they are stranded here at the iliac vessel crossing, or else they are at VUJ. So these 3 constrictions one must know. VUJ is a vasicureteric junction. At these places, one must be careful and look for calculi. Renal mass, renal mass can be properly seen. Any enhancing mass, unless proven otherwise, is malignant. So renal mass, if you are coming across, which is showing enhancement, then it is a malignant. One can look for the local spread as we had talked about staging. So local spread, involvement of fissure urota, one can see extension into the renal vein and IVC. So all these features are really important to know. One can even properly explain these masses depending on this particular mnemonic. It is called renal only. So what exactly is the size of the mass, whether it is more than 7 or it is 4 to 7 or less than 4. So likewise is the R is the radius. Then we are having E for whether it is exophytic or endophytic. So how much is more than 50% exophytic or it is completely endophytic sort of. Then one has to nearness to the hilum, whether it is near the hilum or away from the hilum, whether it is anterior or whether it is posterior. Also, the location relating in relation to the pole, upper pole or lower pole. Why all this sort of nephrometry should be done? By that way, you can even suggest or you can all these masses can be treated by a nephrectomy, which may be subtotal or partial nephrectomy. See here, not only the focal or the organ related disease, we can even see generalized sort of disease. In this patient with the lymphoma, one can see conglomerating nodal masses here encasing aorta and associated splenomegaly. So this one is case of the lymphoma. One can see here mesenteric lymph nodes, here again conglomerating nodes here. So lymphoma for staging or lymphoma as well, one may go ahead with further evaluation by the PET-CT, CT scan with additional information by virtue of giving IV contrast like here FDG glucose. So by that way, you can even know about the metabolism of these masses. At last interventions, we had talked about CT guided FNAC biopsies. One can even go ahead with some CT guided interventional procedures. Thank you.
Thank you so much, sir, for
So it
for a very informative session on CT abdomen diagnosis.
I will
And if any questions from the participants, please write it in the chat box. If any questions from the participants, please write it in the chat box. Meanwhile, I would like to invite our president, Dr. Subhash Wage sir, for sharing his views.
Thank you, Dr. Trupti Madam. CT scan remains the important diagnostic modalities as it not only provides the high resolution but contrast imaging of both solid and hollow viscera. It is not only important in picking the obvious pathologies like masses, obstruction, or bleeding, but it is also important in picking the smallest collection of the fluid in the abdomen and the ball vowel enhancement. So it remains a very crucial and important modality of diagnosis of abdominal disorders, including acute pancreatitis, chronic pancreatitis, ascites, hepatocellular carcinoma, as sir has very rightly pointed out about the different pathologies of kidneys, etc. And sir had done this very wonderfully. And again, it is always an academic feast to listen to the sir. I always say, I'm very much thankful to sir again highlighting us and making us wiser in this area of diagnosis of CT scan related to abdominal disorders. Thank you very much.
Thank you so much, sir, for sharing your views. We believe that by coming together and sharing our insights, help us all to enhance diagnostic accuracy and improve patient outcomes. Thank you once again for being here. As we come towards concluding our webinar, I would like to invite Dr. Sapna Purohit Madam, Associate Professor RTAM Akola, for giving vote of thanks. Dr. Sapna Madam, over to you.
Am I audible, ma'am?
Yes, you are audible. Yes.
Yeah. Good afternoon to all the dignitaries present here. Myself, Dr. Sapna Purohit, Associate Professor, RTAM Makola. Being the member of RVPGA, I deem it a great honor and privilege to post a vote of thanks for today's webinar. To begin first and foremost, I would like to express my deepest gratitude to our esteemed speaker, Dr. Anand Hadgaonkar sir, on behalf of whole RVPGA team, who spared his time from his busiest schedule and empowered us with such an insightful and informative lecture on city abdomen, covering all the important and minor details which will definitely be helpful to our all the doctors in diagnosing or reading of city abdomen. Thank you so much, sir. It was really an honor to hear you. Next, I wish to express my heartfelt thanks to our esteemed president of RVPGA, respected Dr. Subhash Wage sir, whose vision and leadership has brought everything possible on this platform. Thank you so much, sir, for your valuable guidance and support for all of our Nidanians. I also express my sincere thanks to Dr. Trupti ma'am, coordinator for today's webinar, for her excellent planning and execution. Thank you so much, ma'am. I express my sincere thanks to technical team and all the team members of RVPGA for their support in making this event a great success. Finally, not the least, I thank all your participants for being present here and for their valuable and active participation in making this webinar a rebounding success. With this, I hand over again Dr. Trupti ma'am for final concluding of today's session. Thank you everyone for your patient hearing.
Thank you so much, Dr. Sapna Madam. Thank you. As there are no queries, so with the permission of our president, shall we conclude today's webinar here?
Yes.
Yes. Thank you once again on behalf of RVPJ, all the participants, and Dr. Anand sir. Thank you so much.
Thank you, sir. Thank you.
And please request the audience to join us on in Diagnocon 2025 on 14th September, MRI Diagnosis National Conference.
Yes, all the participants are requested to join us on the national conference, which will be held on 14th September 2025 at Nagpur. Shall we conclude, sir?
Yes, fine, we can.
Thank you, sir.